Scary to sneeze in there now.
All right.
I know. We're live.
Power, geez, I swear.
We are live. And this is Senate Health and Welfare. It is February 15th. This morning, we're looking at two bills. We have a short meeting this morning, because we have a joint assembly for some elections. So today we're looking at S-186 and S-189. And Katie, you're gonna give us kind of a 10,000-foot reminder, and then we have a testimony from two folks.
Katie McLeod, Legislative Council. I'm gonna share my screen briefly. So this is S-186, which is naturally linked to the systemic evaluation of recovery residences and recovery communities. And as the name suggests, this is asking AHS to do an evaluation. It's drafted to sort of happen in two parts. So the first part at the top of page 2 is due on August 15th of this year. And that asks the agency to submit a report identifying the framework, outcome measures, and evaluation methods to be used in the evaluation, as well as the key components of service to be evaluated. And then the second part is due November 15th, and that is the actual evaluation itself. And then in subsection B, it lists all of the criteria or data points that the evaluation shall address. I can go through them, or if you want to just move on to witnesses. Okay.
Well, I'm sure our witnesses are gonna have a lot to add to this, so. This reminds us that, and we do have a report that Kiki, you put the report up from the Department of Health on recovery residences. Maybe we can put it up again for today along with the bill. And as you look at the report, and Kelly's probably the best one to talk about this, but there's very little in there about evaluation. It's mostly about who's being treated and how much it costs for treatment. So let's, any questions for Katie? Okay. Yeah, so when I introduced the bill, it was really an opportunity for a placeholder so that we could work further with Department of Health and but in the Office of Prevention. So do you want to testify together? How are you doing that?
Senator, it would be probably make most sense for me to go first, because I have a little bit of groundwork, and then to pass it off to Deputy Commissioner Dougherty, if that works for you.
That's perfect.
Okay, so should I jump in? Good morning.
Good morning.
For the record, Monica Hahn, the Chief Prevention Officer for the state of Vermont. So it's just as a quick about a placeholder, a little bit of place setting. The role of the Chief Prevention Officer, as designed by the legislature, is to focus on leveraging and supporting work across state government and in partnership with our community partners to really focus on upstream prevention efforts in multiple areas. So everything from suicide to chronic disease, to healthy aging, mental health issues, absenteeism and truancy in schools, poverty. But there's a very special focus on substance use disorder and prevention of substance use disorder. And as a member of the Substance Misuse Prevention Oversight and Advisory Council, it became very clear to me in the first few days of the work that I'm doing around prevention that recovery is really a part of our prevention effort. It's a little bit further down the line, but when you're working on recovery and supporting people in recovery, it is absolutely a prevention strategy. So that's kind of my connection to this recovery bill. So as we're looking at S-186, as Senator Lyons said, it really was a placeholder. But a strength of the bill is the idea that we start to move towards a cohesive system of care for the recovery work we do here in Vermont. That we look at a framework for how those residences and communities are built and sustained, that we identify the outcomes that we are trying to achieve so that we have a sense of when we're being successful and what needs to change in order to be successful. And that we work to identify what works well so that we can replicate the successful components. I'm sorry, I don't know why I'm talking so fast.
Take a breath.
A little bit happy. So that we try to replicate the successful components of a recovery residence, because we know that things work in one spot and maybe don't work in another, but I think really trying to see, what are we looking to see in each of those? What are the actual components that we think need to be put together in order to actually create a successful pathway to recovery? Recognizing that no matter what we do around that, each individual's journey is so individual, right? Each person has their own path, but what you need to do is put the right pieces together so that they can pick and choose to move along that path. So what I want to share today is some work that's been happening actually since last summer, and Senator Lyons has been engaged. But a group of us with Senator Lyons and the division from the Division of Substance Use Programs in the Vermont Department of Health started working in June with the Fletcher Group, who came and presented, I think, to a joint group of Senate Health and Welfare and House Human Services, I think last June. So Governor Fletcher from Kentucky, I was going to say Tennessee, I don't know why,
Yeah.
Kentucky, since leaving office has done a tremendous amount of work, he's a physician, done a tremendous amount of work around the country, creating opportunities for recovery residences to be stood up in states. Did a tremendous amount of work in his own state and then started working with HRSA. And got a grant through them to actually work directly with states that are interested in advancing their recovery work.
State person,
HRSA,
was that state?
HRSA. I'm gonna follow.
Human Resources Service, no?
Health Resource Services Administration.
What is it?
Health Resources Services Administration,
Health Resource.
federal agency.
Federal agency,
Got it.
exactly.
And it's a SAMHSA grant that they have funding, they've got a huge, yeah.
Yes, so they have the ability. I know, so SAMHSA is the Deputy Commissioner's already,
Substance Abuse and Mental Health Services Administration.
thank you. You get so attached to your acronyms and then you forget that you need to actually speak like a real person.
They also forget what they mean.
So we've been working with them since they presented to the legislature, because they also met with myself and met with Governor Scott. We've been working with them because they have the ability to do this consultation with states. And so from that initial meeting in June, we've met with them 4 or 5 times. To just explore what kind of technical assistance they have to offer and some of the work that they've done in terms of recovery residences. So their focus really is on a couple of different main areas. They focus on how to braid funding to enable communities to stand up these residences, these recovery residences. They really focus heavily on measuring ROI, or return on investment. So how much money is going in? How do you actually equate that success and the savings to the state, or the revenue to the state when somebody is successful in their recovery and sort of re-enters the community, becomes a part of it again. And they also work on outcome measures, both at the individual level and so how does an individual experience a recovery residence in their treatment and their stay in that recovery residence, but also how do you measure the outcomes and the output of that particular home? Because again, I think that he, like any elected official, is interested not only in the success of the individual, but in making sure that it is a cost-effective, strategic investment when states are doing this. And so that's really where their focus is. Our hope was to use our time with that group to do some of the work that this bill actually already imagines, in partnership with organizations like VAMHAR, so the Vermont Association of Mental Health and Addiction Recovery, and VTAR, which is the Vermont Association of Recovery Residences. Our hope was to work internally and with those 2 partner organizations to create a sustainable, successful network of recovery residences with a clear connection to funding, to understand how that works. Because it's not only state funding, there are private dollars that go into these recovery residences as well. And actually payment in from individuals that are a part of it. There's a women working that's also part of recovery residences. We wanted to be able to look and identify recommended components of care. So what should be a part of this recovery work? Because again, each each one is a little bit different. Some are state funded, but many are not. Many are privately funded. So trying to build a network that actually bridges between those two, state funded and privately funded, and identify what are the components that we really want to see, that we think are best practice. That's part of the work that we want to get done. We wanted to make sure that there could be a focus on quality and on outcomes, and of course, the ability to meet the needs of residents along the way, recognizing that it's a continuum, that some people will need to be in for shorter stays, some people longer stays. How do our recovery residences actually address that? So on top of, so that, all of that focus, we could really create that. That would be added to the work that already happens through the National Association for Recovery Residences, which does set out a certification. So in Vermont, you can become a certified recovery resident through the Vermont Association for Recovery Residences, or VTAR. So there, that already exists, but it's but not every recovery residence seeks that certification. So trying to build on top of what we already have in Vermont and to add a little bit more to really create a framework and a set of guidelines for how recovery residences would work. So that's the work that we've been trying to do, which I think is reflected in the intent of this bill. We were also very interested in the Jenna's Promise model, which, as most of you know, is actually, I keep calling it a recovery community, which is truly just a phrase that we coined. I don't think it's a real thing, but it would be worthwhile to define that. But it's a recovery residence that brings, again, all of these different components into the mix. So employment, and the opportunity for physical health, the opportunity for mental health and wellness. They kind of put intuitively all of these components together. Many of our recovery residences have access to that in communities. They might not need to all bring it in-house to make that happen, but identifying that all of those components are part of a continuum would be really important, because then when you're citing a recovery residence, you're looking for, well, what's available in the community, or what can you bring in-house, because we know that these are the things that work. I also just would like to say, just publicly and out loud, today is actually the 50th anniversary of Jen Pietro's passing. And so I know that for our family, and Jen's Promise is really celebrating that today, in the sense that it's offered so much hope in terms of recovery for other people.
And they were here yesterday.
Oh,
It's really good to see them.
yeah, good, that's great. So to that end, what we did was we developed kind of a charge document for our work at the Fletcher Group, because every meeting thus far, and we've had 3 or 4, have been far-ranging and broad in the spirit of all those conversations. It was very much a blue sky kind of conversation. We could do this, we could do this, we could do this. But we realized that that's never a good use of time after the first few sessions, right? Eventually you have to sort of narrow down what is it we're trying to accomplish. So we developed this charge document, which again, I think really aligns with the spirit and the intent of this bill. And it would enable us to utilize the Fletcher Group, because they have this grant, because they're allowed to offer technical assistance free of charge to states. If the Fletcher Group agrees with the charge that we laid out, they can help us to move some of this work forward, which would be lovely, because it's a large body of work. And we are not looking to add additional people to do it. We want to leverage the resources that are available to us. So I will say that I do have the charge document with me. I'm happy to hand it out. It's very much in draft form, so that would be helpful for the community.
Yeah. If you have some of your summary comments that we could post as well.
Yeah, I can send those to you. I will say that we have worked this through internally. Senator Lyons has had the opportunity to see it. I've sent it to the Fletcher Group for their review. I did review it with Vampar. I have not yet reviewed it with VPAR, so I feel like that's a body of work that I still need to.
Can you give one a Katie?
Oh, sorry.
No, that's okay.
No, this,
No, you can. She's got it.
Got plenty of copies, so.
Katie.
Thank you.
Sure. So just to look at the charge document, what we are asking the Fletcher Group to work with us to do is to create a comprehensive inventory of all the recovery residences in Vermont, both state funded and privately funded. Because as I said before, some of them are state funded, but very few. A lot of them pop up. And so what we want to do is know who's out there, what's the lay of the land. We wanted to be able to assess the current capacity and ability for those recovery residences to collect data to inform outcomes. Because again, as things spring up, what kind of capacity do they have to look at their outcomes? And how do we try to systematize that in some way? Wanted to be able to assess their potential for capacity in data collection, because that's not something that you normally build in. If you're focused on the people immediately and their immediate needs, you're not necessarily saying, oh, we need an evaluator. Is there a way for us to help with that so that we can better understand what we're doing from these recovery residences? We wanted to look at what it would take to build data systems. Is there a way for us to have a single data system that everybody can utilize? First, that sort of makes it easier for us to collect that data. And secondly, it's a way that we might be able to offer technical support to any organization that was starting to work on recovery. Wanted to help Vermont to develop a framework of those critical components that we've talked about and measurable outcomes for the recovery residence model and a recovery community, and sort of define how those connect to those existing standards that VTAR already uses for certification. So again, all of this is intended to leverage on what already exists. We're not trying to duplicate or create something brand new, but rather really look at the strength that's already in our communities and build on top of that. Hoping that they can help us to assess our capacity to build and sustain alternative payment models, since they have a level of expertise in that graded funding that we might not have in the state. Technical assistance to the Division of Substance Use Programs at BDH and how to build sustainable funding. And then finally, a systems mapping exercise, which would really help us to understand the availability of all of those other supports that are so necessary to recovery and sustained recovery for individual, including the availability of housing and economic supports, peer supports. So what's the inventory of where those are and how they are located or co-located close to recovery residences. So it's really operational work, but it's work that would take a lot for us to do in-house, and we could really use an outside eye. That's always really helpful. So that's the draft charge document. With all that said, we have done a little bit of thinking about the bill as it looks right now. And I know that DSU has some suggestions for how we might change some of the language to align with the work that we've already been doing and with the charge. And it felt like, Senator, that you were open to that idea.
Oh, yeah, absolutely.
So that's what we were hoping to pitch this morning to all of you. And with that, unless there are questions, I can turn it over to Debbie.
Can you give me an example of another recovery community other than James Promise?
There's not one, Senator, that is built the way that Jenna's Promise is built. There are many recovery residences that work with employment services or work with a community health center, right? But they're not put together the same way that Jenna's Promise is. The question about Jenna's Promise that I always ask, and Gregory and Greg, Tetro and Don have all heard me say the same thing. It's not clear to me how much of it is literally the power of their personalities and the connection that they have to their community, that they were able to create what they did, and how much of it is really replicable. And that's what we're trying to figure out. Also, is it cost effective to bring all of that in-house? I mean, literally the Tetros bought businesses and created them to employ individuals that were working through their programs. Not everybody has the capacity to do that, but we have organizations like Hireability or even Working Fields that work really specifically to get individuals in recovery employed. How do we make sure that they are leveraged with recovery residencies now, so that we're just building those same things, just not in the exact same way?
So do you have any idea of how much money the state of Vermont's spending right now on these programs? We just had the recovery partners in yesterday, and they're asking for $4.5 million.
That's it, yeah. So there is a report that you have that looks at three, and I'm looking at you and Deputy Commissioner, that looks at 3 different recovery centers.
Yes.
And where their funding comes from, so it's public and private. So if you, the
So
report,
we have that in our.
we have the report, but it doesn't include all of the recovery centers and support.
But that's certainly
services.
information that we can get to, and the Deputy Commissioner can definitely.
Because ideally, if we're effective at what we do, all this will go away, hopefully. I mean, there may be a need to keep some of the residual back, but.
Yeah.
I'm just trying to get some kind of an idea of the plan for, we have a crisis now, but over a period of 5 years, it's gonna diminish.
I think hopefully it will diminish and it won't be at crisis. I think that addiction has been with us for a very long
Yeah.
time. Substance use disorder has been with us for a very long time, and so there will always be some need. But I would agree, our goal is to have it not be sort of epidemic, which I think we can all agree that it is right now.
I think my constituents would like to know, how long we're gonna spend this kind of money,
Yeah,
and some kind of idea that's transparent. on what it is.
absolutely.
But the other thing about spending the money is spending it properly and for best practice. So if we can get to understand how our outcomes are improved and what do we need to have in place to improve those outcomes, then it might help us feel better about putting an investment in different places.
The legacy plan, that's what.
Well, that's what we're about. We are about that. That's our goal, is to put that plan in place so that we know we're investing appropriately. So Senator Hardy and Senator Gulick each have a question.
Well, actually, I don't.
Okay.
You're good.
Senator Weeks.
Senator Weeks does. Well, thank you. I want to make sure I understand, because you were talking fast and I'm tired. Basically, the bill, and even with your changes that you're suggesting, is more or less an inventory and evaluation of current resident, recovery centers.
I think inventory, evaluation, but even more importantly, even to me, is that development of a framework, a set of, kind of a North Stars. If you were gonna pull together a recovery residence, if you wanted to, we've got some that have come in privately. I think about Blue Sky, which I think is down in, I can say Brown,
I think so.
area.
It's down there. somewhere.
So Troy Anastasia from the Van Fish started a recovery residence. So is that a recovery residence? Does it have all of the components that we think are necessary to be a recovery residence? What kind of work is it doing? If it wanted to be officially recognized, and I don't mean to put excess pressure on an official sort of, wand waving or designation, but I think what we owe to families, to individuals in recovery, to the people of Vermont, is to be able to say, this is a recovery residence. And when you say that, you know that it means this, 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 and this. This is a recovery center, and that does a different kind of work. And this is a place where, peer supports are offered, or it's peer and sober housing, and that means a different thing. We have so much language around substance use disorder, and I think it's not always clear what each thing means.
Yep.
So the idea of a framework,
Yep,
Senator,
okay.
I think is what
Yeah, because
We'd
there are
love
some
to
that are
see.
not really doing anything for support, or very, very little for support. They're
Correct.
just providing a room,
correct.
which is important, but
Right.
doesn't have
And
the,
that might be a spot on the continuum, but what do you need to work through to get to that
Yeah,
spot? What makes
okay.
sense?
and so
and-
that's,
go
one
ahead,
more
finish.
question. And what I'm hearing is the connection to the organization, the former Kentucky Governors Organization, is that they have a grant that could help fund some of this. So you're not asking for money in association with
Correct.
this, okay? And this also is across the board types of recovery, not just focused on opioids, it's also alcohol, substance use broader. Okay.
Absolutely. I almost never will talk about anything that isn't broad substance use.
So and I think ultimately, when we think about recovery, recovery is never. People remain with addiction for the rest of their lives. They have relapses, or they can have relapses, so it's a constant battle for some folks, but the intent here is to provide that framework that allows people to re-enter the community. And then if they need help, they know where to go for when they have a relapse. And maybe Deputy Commissioner Dougherty is gonna talk about that a little bit. So you're right. There's some places that just, you go and you have your bed, you feel like you're better, and then you're right back in the same place you were before when you go home.
Or you don't get better because you don't have the support
Yeah,
in
you
the
don't have what
place,
you
and
need.
people
Exactly.
aren't really doing what they need to do, so.
Yeah.
You have.
I have a question related to your questions, and then I have my own question. So
Nested questions.
Yes.
to Senator Williams, Senator Hardy's point, so is part of the effort to not only look at what we've got and how effective that is, but what we need. The strategic plan for, okay, here we are, this is where we need to be. Over time, we anticipate, being somewhere better in the future. I mean, is it also not just about the present, but about the future of the system, of the system?
That's a great question. I will be honest and say, I'm not sure that we were necessarily contemplating a strategic plan into the future, but I want to also make sure that Deputy Commissioner Dougherty talks about that a little bit, because I think that the division itself does that kind of planning work. I think that this effort was really focused on the critical components of recovery and how we make sure that those are built into the services that are being offered right now. The strategic planning component into the future is probably something more that the division would do. And again, I suspect that Deputy Commissioner can speak to that a little bit more.
Good. And then my question, so these efforts are all necessary. I get it. But why do we need a bill to do this effort? We've got a whole department that's, it's got divisions that are dedicated to this. And if to the point made earlier about a grant, there's no money involved. I don't understand why there's a bill. Why isn't this just something which the department says, good to go? This is one of our goals for the year, dedicate manpower, off they go.
Well, I believe that we actually had that conversation with Chair Lyons, and one of the advantages of any legislation is that it holds us in state government accountable to the work.
Accountable for what? Just to produce a report or?
Well, I think moving through the development of that framework. Will we do this work if we don't have a bill? Yes,
You will do this work,
absolutely.
but if there's nothing in statute or session law, it could be that another administration or another person might not follow up. And so the other piece of it is if we're asking for characteristics for outcomes, we're asking for certification characteristics. That could be any certification, any quality outcomes. So I think it's really incumbent on us to understand what is happening in our communities and to building that continuum of care for folks who are under substance use disorder treatment and care. So I'm obviously I'm a legislator, but so I do think it's very important as we talked about this and we started working with the Fletcher group, we started going down a little rabbit hole when we were talking about some very detailed information of how to measure outcomes for individual patients. That's not where this state is right now, but we can ask for a framework for developing those outcomes. But, we say this is what we're looking for when Department of Health and our chief prevention officer and others go out to work with consultants. This is what we want. We don't want to have those protracted meetings that started to feel really, this isn't helping. So this offers some structure for and establishes some goals for the state and for us in particular to understand what's happening. And we have an opioid settlement fund that can be utilized for at least some of the work that's here. Or I know in the budget, there's a proposal from the Department of Health funds for tuitioning folks to receive treatment, to be paid, get their money to go to a recovery center. That might be something we talk about in here and how to expand the utilization of that fund. We can't pass it. We can ask the advisory committee to think about it. To use that fund to help folks through recovery. And then we can also set conditions. We can set conditions that if you're certified, then you're more eligible you have greater eligibility for funds from the state. And then so without that, we don't know what's going on. So that's all. Yeah. That's why I think it's important.
I have a comment, not really a question, which is just that I'm so excited about this because I often feel in the legislature that we're we're so reactionary, we're constantly reacting. And we're not trying to look strategically into the future. And this, to me, is the start of that process. And I'm so excited about having some structure and some guideposts to future success. Thank you.
It's a good way to say it, guideposts. No, and honestly,
With lots of synonyms.
the work that, our chief prevention officer has been doing and that the Department of Health and Substance Use Disorder folks have been doing is really terrific. It's outstanding. And they're so committed to this. There's no question about it. So right now it feels like a team working together. And I think we'd like to keep it that way.
You said somebody said there was no money attached to it.
Do you want to put money on it?
No,
Oh,
I don't, no, I think that, we didn't just find out we got caught. This has been around for a
long time.
long time, so. I think it's good that we're gonna stop the train, we're gonna develop a plan. We're gonna get all the stakeholders together, and then with that plan, we'll get some kind of an idea what it's gonna cost. And then we can justify the expense by it, because we have a plan.
Should I sit down and let?
Oh, are you set to do that?
I think I am.
All right, well, you can stay there. We might get into a
Oh,
conversation.
that's true. You should.
So Deputy Commissioner Dougherty, welcome and thanks for being here.
Thank you. Good morning, everyone. For the record, Kelly Dougherty, Deputy Commissioner at the Department of Health. And so glad to be talking about this important topic with you all. I do want to start just by clarifying, the Senator mentioned Recovery Partners of Vermont being there yesterday. I just want to clarify, Recovery Partners of Vermont represent recovery centers, which are sort of local, not residential. They're local places where people can go to attend support groups and engage in other recovery, minded activities. They're sort of like a community center for recovery. They don't represent recovery housing. So I just want to make that distinction, that what they're asking for is to support the recovery centers that are community-based, non-residential facilities. And what we're talking about today is actual recovery housing. I also want to sort of expand on this notion of recovery communities. I mean, we talk about Jenna's Promise being a recovery community, but it is arguable that other recovery housing can be thought of as a recovery community because they are very connected to the recovery centers that are in their areas and often are connected to employment services, and they connect their residents, with other services. And I'm not saying 100% of them, but often you could think of them in a way as a recovery community. So as we start thinking about that definition and what that means, I think we could be a little bit more expansive around that. I also want to say that the draft charge of the work with the Fletcher Group really could lay the groundwork for some of what is proposed in the original iteration of S186. The evaluation component that's in the original version of S186, I think, is a little premature and also doesn't give us a long enough time frame to really get any robust evaluation results. Having the Fletcher Group sort of do that inventory of all of the recovery residences and looking at the capacity for data collection. We currently don't get person level data and outcomes on people who go into recovery residences. So I think that developing an evaluation plan is something that's going to take a little bit longer and is going to involve sort of being proactive in terms of, what are the measures that we want to look at? Is it relapse rates? Is it, what is it that we want to look at? And then how can we make sure that there is capacity for actually getting those data? So, and then in thinking about the future, I think that the work that we're doing now, or that we're going to be doing with respect to the Fletcher Group, and then also thinking about a certification process that maybe is a little bit more robust and possibly even mandatory, you know, will help us get a better sense of what the need is going forward. So we're not, you know, I think that down the road, there is the possibility that I think we'll find that we could benefit from more recovery residences, but that isn't necessarily our focus right now. We kind of want to get our arms around what's already out there, and also ensure that what's out there is really meeting the needs of the people who are in the recovery residences, and that we have some kind of quality framework around them. So I did send over to Kiki yesterday a proposal for a revision to S-186 that talks about really focusing on the certification process for recovery residences. And we had talked about potentially, like Monica said, there are recovery residences out there that we don't even know about, just because anyone can really hang up a shingle and call themselves a recovery residence. I'm sure some of them do great work, and I'm sure that there are probably some that maybe don't. So we had talked about potentially requiring that anyone who wants to call themselves a recovery residence in Vermont be certified. So that's a question for the committee, whether we want to go down this road. And I just want to see if folks have the copy of the.
We have both a copy of what Monica brought in, and then we have your recommendations and questions. The first question being about certification
Different thing.
on our
Great.
Senator.
Oh, I see.
What was the question?
Sorry, I was asking Monica if Kelly's thing was different than the thing she had.
Yes, it is.
Yes.
Significant, yeah, it is. So yes, we have it. It's in front of us. So why don't you finish
Yep.
presenting, and then because we're gonna move on to another bill, but this is a terrific introduction to what we are going to need to do.
Great.
Yeah.
I think that since you have that in front of you, I don't have any other comments, but I'm happy to answer any questions.
Okay, so we have Senator Hardy, Senator Williams, and I think Senator Goulart.
Yes.
Okay, you were first. Go ahead. Senator
Oh,
Goulart.
sorry, go
Yeah,
ahead.
go ahead.
Thank you, Chair. I'm wondering if in the future, hopefully we will have some overdose prevention centers in the state. And I'm wondering if there's any discussion about how these recovery communities would interplay with those, and if the Fletcher Group has any experience with that, or if they have the two kind of working together. You know?
I can't speak to the Fletcher Group's work on that. Can you, Monica? Do you know?
No, it's definitely not a question that we have asked. It's certainly different points along a continuum in terms of active use versus being in recovery and looking more at abstinence and movement away. So it's interesting that you bring it up, because it wouldn't have occurred to me to connect it up to.
Be a point of
think
referral.
about it a little bit more.
Yeah,
It could
could be a point of
certainly a point of referral, which should come from one place.
Exactly. That's what. Yeah, I think that overdose prevention centers could serve a key role in helping connect people, obviously with treatment, but then also, you know, potentially to recovery residences if that's what folks were looking for, because obviously not everyone going into recovery necessarily needs to go into a recovery residence.
Is this overdose prevention sites, I'm trying to equate this, is this at least the injection site
Yes.
model? Okay, I just want to.
Yeah.
You kind of dance around topics today.
Yeah, I also want to just make sure, and I think Senator, that you understand this, but I guess just to say it clearly. Once you're in recovery, in theory, you've gone through active treatment, right? So you are solidifying the treatment to stop using in work, and then are in recovery is that maintenance and sustaining into the future, and almost a reintegration back into the community. So it really is, I always have to think about it as this like sort of line that you're moving through, and people sometimes do that.
Yeah, that's what I was thinking.
Yeah.
We've heard that a lot, that
Yes,
there are,
like any illness,
Yes,
there is,
yeah.
you know, there are relapses and there are different components, but I think that I wish there was a great analogy for recovery on the other end. Think about that.
thank you.
Can I ask my question now?
Yeah, please do.
Done.
Yeah.
Kelly, thank you for, I'm looking at the thing you sent, and I was sort of thinking along these lines too, whether or not we needed some kind of certification process, because there's such a range of kinds of programs and what they offer. Does the Agency of Human Services certify, I think I know the answer to this, but I'm gonna ask anyway, certify other types of programs that are similar? Do you certify like nursing homes and all those kinds of those?
Nursing homes are overseen by Dale, and
Okay.
their licensing division. There already is a certification process for recovery residences, but it's voluntary. So, and that's run through VTAR, the Vermont Association of Recovery Residences. But, you know, I think our intent here is to kind of make it more universal so that there are some standards of quality and service.
Right, okay. But it is appropriate, because it's not something that OPR does, it's something that AHS.
Yeah.
Okay, okay.
Yes.
Senator Williams.
Along those same lines, thank you for the testimony, I helped to clarify it for me. But, when you said that you don't, there may be, recovery houses out there that you don't know, wouldn't the Secretary of State know? I mean, they'd have to be registered as a business in Vermont, wouldn't they? And how about the people that are working for it? Wouldn't they have to be certified some way by the state of Vermont?
They wouldn't necessarily they wouldn't have to be certified. I think that if they were operating as a nonprofit business, they would certainly be registered with the Secretary of State, but there could be just some sort of volunteer sort of run recovery houses out there. So I think it's a real mixed bag. And I think that the work with the Fletcher Group is really going to help us get our arms around that.
Thank you.
One more question.
Last question, maybe more comment. I'm still a little bit disappointed that there's not, part of this bill isn't about developing the strategic plan. Once you get all the data, you get the mechanisms to figure out who's where, Got a lot of people out there that are all moving towards the same goal, but I don't sense that are coalesced. And that's because this is just my perception, may be entirely wrong, but we need to coalesce around a strategic plan, and there's got to be, focal points and set goals. And I guess that's my only disappointment, that this bill doesn't incorporate that effort, that development as well.
But that's why we're here. That'll be our job.
So this may be one step.
Yeah, if we can,
Okay, very
if
good.
that's a recommendation that we would like to make as a committee to add that in, we can do that. And that's exactly why we're looking at this and the way we go.
Can I ask what you, so do you, I agree, I mean, I think that a strategic
I'm gonna say,
but can I, okay.
really
But
quick.
I'm wondering, I would think we would want it to be broader than just recovery residences and have it be more looking at
I'm with you.
treatment, substance
I
use
agree.
treatment and recovery more broadly.
I agree.
Yeah,
We're
okay.
good. This is gonna be great. We're gonna have fun with this one. I can't tell you how much I appreciate the work that you both are doing with us on this. It's been fun working with you since last whatever. And we'll just continue to chat. I think what we might do is try to translate some of what we've heard here in committee and with each of you, and probably with Katie, to maybe get some language that changes the language that's in the bill, to see how far along we can get. But we'll be a little bit of a heavy lift for a while, so we'll have to do that. But
Sounds good.
thank you both.
Thank you so much. Thanks for.
Great.
Thank you.
All right. That was fun. So now we're gonna move on to S-189, and Katie, I think here we are. So I think if you come up, and then everybody in the room is going to want to say something. This, we're gonna open up a bit of a conversation. I do wanna make a hard stop around 5 after, 7 after, because we need to talk about our field trip that we're taking. Okay, yeah, you bring your lunch, no.
So excited. We have to
Don't bring sharp.
walk in a straight line.
Don't bring sharp.
The sharps. So.
So Katie's put together a new draft. Remember, we talked a little bit. Why don't you tell us? You do it.
Sure. Good morning again, Katie McLean, Office of Legislative Council. So based on Department of Mental Health's markup that they presented to you last week, and an email that the chair received from the Department of Mental Health last night, I was asked to put together an amendment, which I have done. And that is available on your page. So the changes are highlighted in yellow. One of the big changes that you heard from folks that testified was the idea of not calling the product that's being developed by the department protocols and instead calling it guidelines. So that is one of the big changes you'll see here. Also, it's replacing the second subsection B, with an entirely new language about stakeholders to consult with. Previously, there had been language about memorandums of understanding with other state agencies that might be providing some type of mental health services in some form to use these guidelines, and that language has been removed. So go over it in more detail. Title would be Mental Health Response Service Guidelines. The department is to develop guidelines for the use by municipalities, including use by emergency medical technicians and public safety personnel, such as law enforcement officers and firefighters who are employed, volunteer, or under contract with the municipality. The guidelines shall recommend best practices for de-escalation and for mental health response services, including crisis response services. The department shall make the guidelines instead of distribute, shall make guidelines available to municipalities and publish the guidelines on the department's website. And then the new subsection is that in developing the guidelines that are required pursuant to subsection A, the department shall consult with the following entities: Department of Health, Dale, DPS, Vermont Care Partners, Vermont Psychiatric Survivors, Vermont Chapter of NAMI, Vermont League of Cities and Towns, and any other entity that the department deems appropriate. And then changing the title of the bill on passage to read an act relating to mental health response service guidelines instead of protocols.
Okay, and this, so the recommendations came from the ring around the room. And we're appreciative of that you've looked at it and done that. So, questions for Katie on this? So what I'd like to do is to have folks who are here in the room who have looked at this to introduce themselves individually, that can make a comment. I know that Senator Hardy has a question. You have a question.
We can do that first. I mean, it's such something that.
Okay, so who would like to take the lead on this? Sorry, thank you. And if you want to stay where you are, you can do that, or you can get up. So here.
I'm already at
You're already here. Bill, thank you for being here.
$1 late and a donut short, but I'm here. So for the record, Maureen Fox, Director of Mental Health Programs, Department of Public Safety. Thank you, Madam Chair, for having us today and allowing us to just speak briefly about this. And I know we have some time limitations. I do as well. So I was pleased to hear your time limitations. So I will be brief in my comments. It's been actually a great process working with Department of Mental Health, folks from Department of Health, as we've looked at this. And I think we've captured the spirit of what the chair was looking for in developing guidelines. Because we do have a lot of emergency responders throughout the state, responding to people who are in various types of crises, mental health crises, addictions crises, et cetera. Madam Chair and myself have had conversations over the years about fidelity and consistency in responses and such like that. And I think this really moves us in a very strong direction towards that by working together and bringing together all these stakeholders that we've listed here to really work on developing these guidelines that will go statewide. And I think it has the strength and power behind it of the department to say, look, these are recommended guidelines. We can't force, an individual entity or whatnot. But from a best practice perspective and a guidelines perspective, having this information out there across the board, I think is incredibly powerful. And in talking with my leadership at Public Safety, we're committed to, once these guidelines are put out and developed, we're committed to taking those guidelines and through our normal process of reviewing on a regular basis our policies and practices around interacting with people experiencing mental health or other crises, looking at these and incorporating them as fit into our practices as well.
Terrific,
I will
thanks.
keep those as my comments,
Yeah.
unless there's questions.
Who's next?
Thank you.
Down the road.
You just,
Go right down the road. I know, you haven't been here before.
No, thanks for having me. My name is Jeremy Carrigan. I'm the Crisis Program Director for the Department of Mental Health.
Oh,
And
welcome.
so, one of my roles at the department would be to, make a guideline practice for first responders. I oversee the crisis programs in the state, being, alternatives to emergency rooms, 988 and mobile crisis. And so I have that lens to hopefully have alignment and best practice guidelines that the trainings that those programs do also have first responders do. And so everyone in the state who sees a mental health crisis will hopefully have guidelines to be able to respond to them.
Thank you. Thanks for your work. No, it's not an easy place to be. Who's next? Okay, welcome.
My name's Will Lyon, and I serve as the Director of Emergency Preparedness Response and Injury Prevention at the Health Department, and I oversee the Office of Emergency Medical Services. EMS clinicians across the state respond to mental health crises day in and day out. I think, as our folks, the 3,000 plus clinicians across the state, are engaging more and more with folks who are seeking that type of crisis intervention. They welcome the opportunity for more consistent and more up-to-date training, so to be better equipped to provide the intervention and to connect them to the resources they truly need. In the EMS sort of world, the word protocol really means something very specific, and that is what's referred to really in a bigger picture perspective as the standard of care. So we have what we refer to as a technical advisory group that is made up of stakeholders from across the state. We have physicians, we have EMS clinicians, we have service leaders, Deputy Commissioner of Public Safety sits on our technical advisory group. Right, so we bring in all these industry experts and stakeholders to help inform the whole development process. And so we would welcome the opportunity to bring folks from DMH and others to inform what would ultimately be looking towards taking these guidelines and integrating them into what would be an EMS protocol that would be included in our statewide protocols. It's important that EMS clinicians, when they're operating in the field, sometimes time is short and, there's a lot of emphasis around solving the problem quickly. We want to avoid a situation where they are having to reach out to different types of resources to figure out, which clinical standard do I need to advise on in this case. So if we're able to consolidate all of our protocols into a single document, which is what we've accomplished to date, that would be our preference, in that any type of protocol or guideline is integrated into our statewide protocols. And so it's a single point of reference for the clinicians in the moment to be able to pull off, or grab the book off the shelf and pull the app up on their phone. And they're not looking to multiple resources from multiple state departments. And then lastly, when we have clinicians, they maybe we're on call and things didn't go quite right, and they end up in front of their district medical advisor, or in some cases even the state. someone has to take and sort of be that in that role of clinical oversight. And, this would be another case where if this guideline or protocol lived under a different department, we'd be relying upon another department to provide clinical oversight, and it would also be, potentially, filling the role of, sort of evaluating someone's care and determining whether or not it impacts their ability to hold a license or if there's a suspension. And then, that's something the Office of EMS has been doing for decades. I would say we have a really respectful relationship with the EMS community. And we would ask that we are able to maintain that. And again, we welcome DMH and others into our technical advisory group. It's a very well-established process. The team meets once a week, and we update our protocols every 2 to 3 years, depending on sort of the breadth of changes that are being considered across the entire spectrum of the book. And they're actually working on that right now, as we're hoping to roll out the next iteration next year. So, depending on sort of the velocity at which this bill moves and the opportunity to get this ball rolling, it could very well be included into this protocol revision. If for some reason the timing didn't work out, that's okay. We can always open up individual sections of the protocol book and do sort of a mid-calendar update as compared to waiting until the next, total update. So we can adapt to it. Our ask is just that it's included in our very, pre-existing process. So,
Terrific, thank you.
yeah.
That hopefully be incorporated into your training too.
Yes. And it's an area that we recognize. Historically, EMS clinicians have received very little training. Folks will say, we spent a half a day on it. We look at the complexity and the role the EMS clinicians are playing today. There's clearly a need for more than just a few hours of training and education on what is a really significant segment of our work today. So you're absolutely right. We would be looking at changes to initial education courses and how we modify that curriculum. But then anytime there's a protocol rollout or a protocol update, there's always a training package that goes out with it to guide folks through what are the changes, what's new, things like that. So a training component would be a vitally important component of that.
Senator Hardy had a question, and then Senator Weeks has a question.
Thank you. Thanks, Will. It's nice to see you. So you were addressing one of the concerns I have with this
Sure.
bill is that layering guidelines on top of protocols that are well established.
Right.
And you have this process for developing protocols, and so does law enforcement and firefighters, and everybody has protocols that really mean something.
Yes.
So you said your ask is to make sure that it is integrated into your process. Is it in this bill, or do you need something else to ensure that it's integrated?
We feel comfortable that with the language that's in the bill now, it would give us the flexibility we need to bring it into sort of the funnel that we would, or the funnel that would lead to our technical advisory group, which is our
Okay.
protocol group, looking at that. So I'm comfortable with language the way it is in the revised bill.
And what if the guidelines that come out are not something your group necessarily agrees with as part of protocol, or if there's some kind of at odds?
Yeah. So I think that's where you get into the conversation around, is it a guideline or is it a hard and fast rule?
Yeah,
And that's where I think sort of the difficulty you run into when you say something is a hard and fast rule is that you leave someone no choice. And it becomes very black and white as to whether or not you follow the standard of care or whether there was flexibility in the moment to consider other options. One of the steps that we take, and certainly it's been evolved over the last few years, is slowing these types of calls down and reaching out to real resources, right? There aren't a lot of these cases that are life and death in the moment we have to make a decision in the next few seconds. Our position working in conjunction with public safety and others is to basically communicate to folks, we need to slow down. We need to make sure we understand the problem. Let's pull in the subject matter experts. If we're talking about more of a guideline, which I know the language now is really focused on the guideline, it basically gets our folks to a point where they have options to consider. And as compared to a hard and fast rule, which would say you shall do this in the moment. And that's where we really create the potential for danger for clinicians, because if they don't do that prescribed thing, if something were to happen down the road and there's some type of litigation over it, they're going to, EMS clinicians will be judged against what is the standard of care, and you either followed it or you didn't.
Right.
And if the answer is that you didn't, then we're talking about, potential actions against someone's license. And I don't think that's the right solution here. I think we want to create a situation where we are, giving folks the flexibility to rely on the training and expertise and to utilize these guidelines that include reaching out to subject matter experts to figure out what's the right solution for this particular situation. Does that answer your question?
It does, I mean, and this whole conversation is why I still have concerns about this, even though they're changed to guidelines, and I appreciate the difference between guidelines and protocol. But I really want to hear from the Vermont Criminal Justice Council, because these guidelines would also be about law enforcement. And law enforcement also has very, very strict protocols that they're supposed to follow. And
Yeah, you're right, and that's why I'm looking at Morning Fox, and we might wanna,
well, really, we should hear from Heather Simons, who's the head of the Vermont Criminal Justice Council. And they are revamping their protocols right now. And it may not align with their timeline very well or their processes. And down the hall, we do this. That's what we work on and GovOps.
so the timing of that would be important to consider. We can have Heather Simon.
Yeah, I want to make sure that there's not a conflict, and it's because there are lots of cases where it is life and death, and if you make the
Then we'll
wrong call.
exclude them from utilizing the guidelines, but it sounds like the guidelines for mental health, how to treat someone in a mental health crisis response might be helpful in offering flexibility and who to connect with or not, what kind of service to offer someone. That's what I'm hearing. I'm not hearing there's a conflict necessarily, but we can, if you can give Kiki the name of the person and the contact, we can bring her in. Do that.
Yeah, I mean, I think that if you exclude law enforcement from the guidelines, that also makes them.
Well, I'm not
You know,
saying that would be the worst thing to
That
do.
you don't want to do that, but you also don't want to include them in a way that conflicts
We
with
just
their-
want to make sure that it'll fit in with their protocols, and I'm looking over at Morning Fox, can you answer that question?
I don't know if I can completely answer it, but just to add to it, and I appreciate Senator
Yeah,
Hardy's concern. But I think as Will was speaking, being guidelines and being kind of recommendations, here's best practices, different things. That wouldn't box in law enforcement or the Criminal Justice Council to have to adopt
Right.
all the guidelines within there. It's just kind of a reference point to say, here are things that maybe the Criminal Justice Council should consider as they're promulgating their own protocols, policies, et cetera.
That's exactly what they are.
So that's kind of from public safety, how my leadership has looked at this. That
Yes.
we'll look at these as we review our own policies and practices around interacting with people having, a crisis.
Yeah, and it encourages the continuing dialogue with the
Right.
Department of Mental Health, which is so critical. Thank you. We can have her in. Thank you. Any other questions for Will?
Just had a general question. So I missed it when Ms. McGlynn went through it, and I didn't see it on the as introduced bill. What's the intended rollout of the guidelines? Like, what's the timeline for rolling this out?
What's the timeline in there right now?
Let's see.
There's no timeline in the bill, it's supposed to
Timeline.
affect July 1, 2024. So I would assume that they have to be up and
We
running.
can put a timeline in if you'd like. We need to hear from Nicole.
Come back to the effective date.
Sounds like there's a lot of,
Work.
There would
Yes.
be.
without a goal, you don't know when you're there.
We gotta get over the, yeah, exactly. Nicole, we want,
Okay.
that's a question for you, I think.
Yeah, I also want to represent Senator Hardy's question as well. My name is Nicole DeStazio. I am the Director of Policy for the Department of Mental Health. And so I am also here to kind of support the the language in this bill. I also want to thank the committee again. I know I did you last time, but again, for kind of bringing this to our attention and kind of focusing all of us on it. It has been a really wonderful collaborative process to work with my state partners and to work with the committee. And sometimes I feel very proud for working for government, and like I can tell, I know government works. And so this is one of those times that I'm very happy to be here with all of you. So I do want to like back up again, because I feel like I heard your question a little bit different, so I just want to kind of check in with you, but it sounded to me like one of what you were saying was, you know, we put together these guidelines and then somebody, law enforcement or someone else looks at it and thinks like, I don't like this and I don't have to do it. And so thank you very much. They've been distributed and made available and I'm going to pass on it. And I just want to say, like, I think that our process would actually be more collaborative and inclusive with those partners. So I don't think that we're not planning to like get to the end of this and say, hey, law enforcement, here are guidelines. You know, it will be a collaborative process to begin with. So if they feel like we're not gonna say yes to this, or this doesn't match with how we do business, I feel like we would catch that earlier in the process and make revisions before we would finalize them. So I don't know if that helps to answer anything for me.
Yeah, I mean, well, first of all, they're not at the table. I mean, Department of Public Safety is, so, but other law enforcement is not at the table as the way the bill is drafted right now. So if that's true, then
Oh,
you
yeah.
have to include them in the bill, not just as optional partners. Because if you're gonna, these guidelines for law enforcement, they need to be at the table. And so I think Criminal Justice Council at the very least should be there. But my concern is not that, it's more that the guidelines and the protocols might either conflict or confuse. And so you're in a situation that's a high stress situation, whether you're EMS or law enforcement or firefighters, any first responders are, and they're like, oh, there's these guidelines I'm supposed to think about, and they're the protocols that I have to follow. And then there's they might conflict or confuse in a moment that's a crisis moment or a life and death moment. And so I would rather that we have the protocols, which are required to be followed, be the things that are really clear and not muddy the water with guidelines on top of protocols. I am not a first responder, but I can only imagine, you know, I just, as a mom being in a crisis situation with my kids, if I'm like, okay, what is the right thing to do here? The guidelines that I heard yesterday in that mother's book versus whatever. And this is not even a situation that's nearly as crisis oriented as what some of our first responders are in. So I don't want to have guidelines conflict with or confuse the protocols that have to be followed. And so that's where I'm really worried. I agree that this is necessary in terms of having better things, better tools, better communication, better protocols and guidelines. I agree that that's necessary. There have been instances in my own community where things have gone awry in the last year. But I'm worried about muddying the waters. So that's why I want to make sure before we pass something else to layer on top of what's already there.
So I'm
It's
gonna,
not.
I'd like to comment on that, and then I want to get to closure because we only have 5 minutes, and we have something we have to do. So I'm just gonna say that my original intent was to have an MOU between the Department of Mental Health and all the organizations that are responding to a mental health crisis response. An MOU is far more difficult and will really firmly establish protocols in place. This puts in place information about mental health response that can include de-escalation and others. I think there probably there is clinical information about de-escalation, but not everyone has it. And we have volunteers in our community who need something. So the guideline could say, do not de-escalate, wait for, public safety. Those are the things that I think are absolutely critical at the ground level in our community. So I'm going to cut off Nicole's response right now, but I'm going to bring you back the next time so we can continue this conversation. And then we will have folks in from the Criminal Justice Council because that's important. And then we'll just move ahead because we need to stop right now. I'm sorry.
No, it's
I'm sorry,
okay.
just getting fun.
No, it's completely okay.
Just getting fun.
No, it's completely okay. I'll just to kind of answer the question of the role. We don't think it will take that long, so we'll be happy to give you some suggestions for it.
All right, that's terrific. Thank you. So we are going off live. We're talking about process and our little, how our field